what are the features of parietal lobe? You get a lot of somatosensory stuff because you know the frontal lobe is the motor lobe, but the parietal lobe is the sensory lobe. So for example, they get this sinking feeling. We had a child who said when he had a seizure, he felt like he was in an elevator that just sunk down to the basement level. You know that feeling, that gravitational feeling? That's what we mean by the sinking feeling in a parietal lobe seizure. You can get a lot of vestibular hallucinations because the vestibular system has connections there, such as vertigo. And in the non-dominant parietal lobe, let's say most people would be the right parietal. You get this left hemi-neglect. You know, if someone has a stroke of the right side of the brain, they may neglect the left side of space, right? Like they'll draw a clock and draw the 12 to the 6 fine, but the 7 to the 12 gets all bunched up. Or a man may forget to shave the left side of his face, or a patient may not realize there's food on the left side of his or her tray. Well, in a parietal lobe seizure from the non-dominant side, you get this asomatonosia where they actually lose awareness that that part of their body exists, sort of like some kind of phantom syndrome. Occipital lobe, obviously you get a lot of visual phenomena. And headaches, especially in children. Children, there's this borderland between epilepsy and migraine, and sometimes they're presenting with headaches and their seizures, especially occipital lobe seizures. In occipital lobe, you're going to see more elementary visual phenomena, right? But in the temporal lobe, well, once vision goes to the occipital lobe, it has to move forward to be processed. You have this dorsal stream of information, the so-called where pathway, which means different neurons are stimulated or inhibited based on the location of whatever you're seeing. And eventually you have this what pathway in the temporal lobe, which means different neurons are stimulated or inhibited based on what you're seeing. So here's the anecdote. I had this patient who's very memorable because she was a college freshman at the University of Virginia. This is when I'm down in Washington, D.C., where I was for years. And to get into the University of Virginia, you had to be a really bright kid. She went to this great high school down there called Thomas Jefferson High School of Science and Technology. It'd be like going to Boston Latin here, I think they call it. And when she was a freshman, she had this bad experience one Saturday night. Nowadays, there's a lot of talk about assault on college campuses, right? Well, she came in and said she had what you would call a quasi-date rape experience, okay? And so she started coming home every weekend because she was so traumatized about being in her dorm on the weekends. But when she drove home, she noticed that there was a figure to her left while she was driving. And she recognized that it wasn't there. She recognized it was a visual hallucination. You know, we're taught in medical school that if you have an auditory hallucination, you think psychiatric like schizophrenia, but this was a visual hallucination. Not that she knew the significance of that, but we know that that means you think of a neurologic problem. And so she had this male figure to her left while she was driving home, and it really bothered her, but she could not identify who it was. Because everyone, including her parents, thought it was this perpetrator of this bad date experience she had, she went to a psychiatrist, psychologist, she went on Prozac, Paxil, and a couple other meds, eventually on Risperdal, or it may have been Mellaril back then. Anyway, on Thanksgiving time, she was home for a couple days from college, and she came in to see me. I was kind of a young neurologist in town, just came from Boston Children's, so I was like the guy to go to. And I didn't know what it was, but we did an EEG, and the EEG was perfectly normal. I had this great tech, and this is the days of paper EEG, so the tech turned off the machine, and then the girl exclaimed, "There he is!" She saw this guy's face to her left, and the EEG tech flicked on the machine, and wouldn't you know it, there was a rhythmic spike and slow wave discharge from the right temporal lobe. And this was a temporal lobe seizure, and this responded right away to carbamazepine, Tegretol, and she had no further problems. I learned this lesson then, that this formed visual hallucination was coming from the temporal lobe, not the occipital lobe. The occipital lobe would give you primitive, unformed hallucinations, but the temporal lobe would give you more formed ones because the visual information is being processed at such a higher order. Hypothalamic. That's a nice example within the arrows of a hypothalamic hamartoma. That's where you get the classic gelastic or dacrystic seizure, either laughing or crying. Mostly laughing. It's not a happy, mirthful laughter. It's an eerie giggle. And patients who are old enough to tell you that they are not happy when they're doing it. They don't find it funny at all. Now, there's a whole new surgical approach to these, this minimally invasive LITT therapy, laser interstitial thermal therapy. The commercial group that has been most active is known as the Visualase. we're calling it laser interstitial thermal therapy because that's what it is. It's heating up the tissue in a safe way where surrounding CSF allows the heat to dissipate and not injure surrounding structures. And auras, we talked about auras. I just wanted to make the point that I already did, that a lot of patients with generalized seizures describe an aura. It's just an aura like, I'm going to have one. If a patient you think has absence epilepsy has a warning, it doesn't mean it's not absence epilepsy, it turns out. I was trained to think that it meant it was a complex partial seizure, what I now would call a focal dyscognitive seizure. It doesn't mean that. On the other hand, if a patient has an aura with certain semiological features that point you to a certain area, like the examples on this slide, that is localizing.